This is Blood and Cancer, the official podcast of MDH Hematology Oncology. I'm the voice of MDH Podcasts, Nick Andrews. And I'm joined, as I always am, by MDH Hematology Oncology Editor-in-Chief, Dr. David Henry. And Dr. Henry, as we record this, we always give like a stupid weather update, but this is the first day that it felt like winter. It was 8 degrees this morning. I bundled up.
On the East Coast, it was terrible. We're 20 degrees below normal for the fall in November. And of course, they're promising a, quote, warm up next week to the 50s. So we can't wait.
And we, everybody that was bundled up in Michigan and Ohio and Wisconsin, hope you dug yourself out and you enjoyed the snow day serendipitously on the same day that the Disney streaming service was announced. So everybody experiencing their own version of climate change, as it were.
Or frozen, that's right.
Well, how do you like this for a podcast segment? As cold as it was outside, we have a hot episode for you, Dr. Henry.
Oh, I like it. Nice segue.
Yes, not cheesy at all. But it is a big show because part 2 of your interview with Dr. Jack West is coming up in this episode. And I enjoyed part 1. He delivered. It was one of those times in life where you thought it could be, there's a lot of hype, and it lived up to the hype.
Yeah, if you missed last week, our listeners, don't forget to listen to it. And if you're rolling along with this one, keep on listening to this Blood and Cancer podcast on part 2. Jack West, lung cancer specialist, City of Hope in Los Angeles, really decodes and dumbs it down very nicely for us to understand some of the clinical trials and how that then is relayed and applied to the clinic. So it's a very nice episode.
Yeah, and he is just a treasure trove of information. And if you are not a Twitter user, or if you are a Twitter user, you know of him. If you're not, he would be someone I would recommend following on the first day.
To follow. A lot of good information on his Twitter. Yeah,
absolutely. He's very well involved. So part 2 coming up in just a little bit, and of course, following the interview, clinical correlation with Dr. Ilana Yurkiewicz. Very interesting topic this week. Something a little bit more practical than I think that she does sometimes. Dr. Yurkiewicz talks about not being the leader or being a covering physician for a patient, not the head hematologist or oncologist on a patient's care, say if a colleague is on vacation or whatever else, and how important it is to be just as present and to take everything just as seriously, as if you need to be told to do that, but a lot more weight than one might think.
Yeah, and I'm thinking as I cover and I'm on call a particular night or I cover on a weekend, the charts, as much as we hate the slaves we become to the electronic medical record and all the input it requires, it really is wonderful record keeping. So you can quickly get up to speed when you don't know a patient at all that you're covering either in the office or on the phone or in the hospital. So as she will discuss, it's important to step up and be available when you're covering which she is early in her career, covering for a senior clinician.
Absolutely. So that's clinical correlation. It's coming up following part 2 of Dr. Henry's interview with Dr. Jack West right here on Blood and Cancer. Before we get to This Week in Hematology and Oncology, a couple of announcements. For the holidays, we're going to give you a few best of episodes that will include our greatest hits for clinical correlation and some other things that we really enjoyed, including a throwback, I believe, to our biologics. Biosimilars.
That was really interesting and well done by him earlier this year.
And we also have a listener survey. If you like the show, if you don't like the show, if you think the show could improve, let us know. There's a survey. You can find the link to it in the show notes. We really appreciate that, and I want to stress that your participation in the survey is anonymous. We're just trying to make the show a little better, learn about you and learn about what you like, and give you a spot to just tell us what you think. So you can find that in the show notes. And one more thing, Dr. Henry and I will be in Florida for ASH, which is the American Society of Hematology. So come say hi. We'll be recording some shows, and we hope to run into you down in Florida.
Agree.
Okay, so it's time for This Week in Hematology and Oncology, and we've got a story that is prevalent to the world of lung cancer. This is Atezolizumab bests chemo in non-small cell lung cancer patients who have high PD-L1 expression. And this is, we talk about it all the time. We just can't talk about it enough, the exciting world of immunotherapy.
So this is a late-breaking abstract from a really quiet, but I think really interesting organization. I've listened in or attended one of their meetings, the SITC, or Society for Immunotherapy of Cancer, and a late-breaking abstract for IMpower, or IMpower 110, where they had this antibody, Atezolizumab versus chemotherapy in advanced non-small cell lung cancer, and the antibody beat the chemotherapy in those patients with PD-L1 expression 50% or greater, where the more enriched the tumor is for this marker, the more likely across all trials where these antibodies are to work. And I'm sure many of the listeners have had experience using these antibodies, and mostly they're not without much side effect. I tell patients, I'm not treating you, you're treating you. We're unleashing your army against the tumor. Sometimes there's off-target effects, which can be significant, and we talk about and watch for. But here, this trial shows that you could do better in these highly expressed PD-L1 positive tumors, non-small cell lung, with the antibody instead of the chemotherapy.
Absolutely. I have a friend of a friend who wanted to ask me how to talk to their grandparent about this therapy, and I said it's Batman therapy. It's a vigilante. Or vigilantizing your immune system.
Yeah, a good analogy.
So overall survival and progression-free survival were impacted. Of course, this is a randomized phase 3 trial. Different subgroups of patients, including with the size of the tumor. So two different groups, the TC3 or IC3 populations, they had a significant OS improvement with Atezolizumab, as did they did an overall survival as well as progression-free survival. You can read the data in full by following the link in the podcast notes, but like we said, it's just more and more and more, and it's going to be every day, and we are so excited to cover it for you, both this week in oncology and with our interview with Dr. Jack West. So it's been a really great month for talking about lung cancer, and I'm honored to, and watch me segue one more time, and thankful to be talking to you about lung cancer and where it's gone in this month to give thanks. So Dr. Henry.
Oh, I really agree. And a shout out again to our resident, I think this week for the two parts of Jack West's interview, Sue Landy did really nice bullet point show notes on the webpage. So if you want to see more and we'll check the references out, you can visit us at mdh.com/hematology-oncology. And we thank you for listening to Blood and Cancer. So here it comes. So much talk about PD-L1. How and where do you get your PD-L1 assays done?
I generally get that at an outside lab that turns it around in just 24 to 48 hours. It's a very quick test that doesn't require much tissue. So there's no best place. It's reasonably straightforward. I would say that the 22C3 antibody, that is the standard that has been well studied in the various pembrolizumab trials, is the clearest standard of care. I wouldn't say that other options are wrong. They're largely concordant with the data from the 22C3 assay and various trials, and the results are pretty consistent that higher PD-L1 is associated with a better chance of a good response with PD-1 or PD-L1 inhibitor therapies, and they are more similar than different, but it's not necessary nor sufficient. There are some patients, a minority, who can have a good response with low or negative PD-L1, particularly in combination. And it's not sufficient either, that having high PD-L1, we wouldn't want to put it all bank on that working. It's not a certainty, even if it is the dice are loaded in your favor. And we also know that there's recent data to support highest PD-L1 in the 90 to 100% range, having the best chance of response compared to 50 or 60%.
Well, I think for those of us in clinical practice, community practice, this clinical and community practice, it's really important to get this done quickly. And I've been sending out as well. And the turnaround is quick and the reports are easy to read.
Yeah, I think the problem is the discordance between the rapid turnaround of a PD-L1 test and the longer turnaround of the molecular testing that you really want to have before you get started on treatment.
Your driver mutations.
Exactly, because we know that the patients who turn out to have an EGFR mutation and also ALK and several other driver mutations don't tend to do especially well with immunotherapy. And it varies based on the driver mutation, BRAF, V600E. These are patients who can do well. Certainly KRAS is different, but EGFR mutation positive, ALK rearrangement positive, these are patients who, if they benefit from immunotherapy, it's not at all close to the same magnitude as the targeted therapy benefit.
Mm-hmm.
And you don't want to start with immunotherapy in these people because there can be toxicity issues of
Sure.
switching from immunotherapy to a drug like osimertinib. So ideally, you really would like to get molecular testing done and have those results before committing to a first-line therapy.
So in the patient whom you can wait, you probably, in my experience, you're talking 2 weeks. You see him or her, you get the testing sent, and have them back in 2 weeks to start whatever.
Yes, and if you're getting it in 2 weeks, that's great.
Okay.
But it does. I mean, it depends. If you're just doing a la carte testing for 3 or 4 different things, the ones that have the most evidence, EGFR, ALK, ROS1, BRAF, V600E, you can order those a la carte and get the results in a matter of days or certainly inside of a couple of weeks. I think the bigger challenge is that now that list is growing and we are about to have very effective drugs for MET and RET available as well, and we have TREC. Once you get beyond 3 or 4, it makes sense to test with a broader panel using an NGS approach. Tissue NGS typically takes all of 3 weeks, if not longer, and I think that's a real journey to go on with the patient to try to reassure them that it's better to get all the information before you commit to anything. One other approach is to consider sending off a liquid biopsy, which
that's
is
right where I was going to go next. So
right.
When do you do that, and what's your feeling about liquid biopsy, which I think is so fascinating for our listeners? I'm sure everybody's heard of it, but I've seen the Guardian 360 people, as one of them, talk about we're all shedding DNA from all of our cells, tumor cells alike, and they can find the tumor DNA and then tell you how much and then tell you if it's mutated. Amazing.
Well, I would say that the data with liquid biopsies, and it may vary by assay, and I would say that Guardant and the Guardant 360 test has a lot of data to support it, and ever more, is that you can certainly trust a positive result if it comes back like that. And so if you send that off, and one of the real advantages is that you can send it and get the results back in 7 to 9 days instead of 15, 20 day calendar or working days, then you can act on that and have some real confidence that the EGFR mutation that's identified in plasma is has as good a chance of being associated with the response to EGFR inhibitor therapy as finding it in tissue. It's just the sensitivity is not as great, particularly in patients with a lower tumor burden, chest-only disease, for instance. Not as much tumor shedding, and not as much of a confidence that a negative result means true negative rather than a false negative. And in that case, if it comes back negative, it's not as helpful, and you may be inclined to still wait on a tissue-based test. So these are some of the issues that we would think of. It's still evolving, and some thoracic oncology experts are inclined to send off both tests simultaneously, or
yes, I've heard that. Yeah,
or send off the plasma. If they get a positive result, stop there and move, or if it's negative, be poised and ready to send off the tissue, but holding off. But there's not a clear best answer right now. I think it'll be a lot better when the technology improves enough that we can expect to get tissue and or blood back inside of 2 weeks. I think beyond that, it's hard for docs and patients to bite their lip and wait that long. But it's certainly the optimal result to wait and get as much information as you can before starting. Some people also are inclined to start the chemo portion if say they don't know, or if the test is negative,
right, to get something going. Yeah.
And get something going, and then add in the immunotherapy if the driver mutations are negative. And if not, then you haven't poisoned the well with immunotherapy that can lead to greater problems of toxicity when integrating in targeted therapy.
Well, I want to close in a minute or two with a case, but before leaving the immunoantibodies, the adverse events we see with them so interestingly and different. Can you name what you maybe see more often and less often? I just tell a patient your army's released and there may be an itis here or there in your tissues or organs. What are you seeing more or less of?
I would say that the most striking thing is the variability. That I've had a lot of patients who you could grill them and they just have nothing at all. But there's others who certainly have had a wide range of toxicities. And I think it's important to know that immunotherapy is not necessarily non-toxic, even if overall it's better tolerated than chemotherapy. The toxicity profile is certainly variable enough that I think that can add a little anxiety in terms of we have a very good experience knowing what to expect with chemo, and immunotherapy is more variable. Most commonly, it's going to be things like fatigue and rash, but as well as things like hypothyroidism, potentially hyperthyroidism. But there's a long list of rare things that can happen and can be quite bad that we need to learn about. In fact, I think it's going to be interesting. I wonder if we will evolve to have specialist teams, maybe based at the tertiary care centers, that eat, sleep, live, and breathe immunotherapy toxicity management, and it's a particular subspecialty. Jarushka Naidu, as a physician at Johns Hopkins, who's really specialized uh, in immunotherapy toxicity management, and she has led some of that effort at Johns Hopkins, where they've done a huge amount of work on immunotherapy in developing a team that's available on demand to manage toxicities. And I think that's an approach that, as immunotherapy becomes commonly used across such a wide range of cancers, there's a very broad array of toxicities that most oncologists are not going to have much experience with. So I think we're going to have to find new ways to contend with that challenge.
Well, to that point, we've been telling our patients if you crash into the ER and the ER physician sees you, we've given them a card with the name of this antibody on it, so the admitting physician or treating physician in the ER doesn't think it's chemotherapy they're on, because there may be all sorts of change from the antibody, and they show them that's the antibody they're on, and hopefully that helps.
Yes.
Well, I want to pose a case as we close that I saw this week, and I thought you might find it interesting to comment. A woman in her mid-60s, healthy otherwise, had two nodules seen, left upper and left lower, and the biopsy showed at least one of them was positive, so she went to surgery for both. And the left upper lobe lesion, they were both non-small cell adenocarcinomas. The upper was 1.4 centimeter in size, all lymph node stations negative, no lymphovascular invasion, no pleural invasion. The left lower lobe lesion was 3.1 centimeter, and same thing, lymph node stations negative, no margins clear, no pleural invasion. So we had at least a 1 lesion, and the bottom one being 1B. And I always think of the 4 centimeter and greater as chemotherapy. Would you recommend chemotherapy to 3.1? And could you comment maybe with or without therapy chances for recurrence of this early stage?
So clarify, you'd said there's two separate lesions.
There's two separate lesions. Left upper lobe 1.4, left lower lobe 3.1, both adenocarcinomas, and both out and both lymph node negative, and margins clear.
So that's well within the range of judgment. I would say that if you view these as two independent cancers, which I think is an appropriate way to view them.
I think so too, yeah.
Then they would each have a less than, or at most 25-30% chance of relapse. The larger one of the 3.1 or so centimeter one being certainly a higher risk. As long as you're confident that the lymph node staging has been thorough, et cetera. And I would say that chemotherapy is a consideration. Adjuvant chemo has more evidence to support it for larger tumors, and we typically have used 4 centimeters as the cutoff. But there's nothing magical about that. And there have been some data to support using administering chemotherapy for larger tumors in that sub 4 centimeter range, 3 to 4 centimeters, even 2 to 4 centimeters, particularly if they have some negative prognostic features, visceral pleural invasion, etc. So it depends on the patient and their health. I think in these settings of adjuvant chemotherapy consideration, I just look at the anticipated risk of recurrence. And I would say that here, having one that is a little below the cutoff and a second cancer, even if independent, only escalates that risk. So it's probably in the range of being right in that toss-up for anticipated benefit. And you have to look also at the patient. If they are 59 or early or mid-60s and fit, then the anticipated toxicity of chemotherapy is modest. If they are 76 and have several comorbidities, the risk may well exceed the anticipated benefit. So the anticipated benefit is still likely to be pretty marginal, maybe in the range of 4 or 5% in an absolute risk. And the toxicities are going to still be present, whether you are treating for a low risk or a high risk. And that's maybe a 0.5 or 1% risk of something particularly bad. And I just discussed that with the patient, and very often they have their own opinion about whether that equation means definitely do it or definitely don't. Because some people, the anticipated what if factor, it's a great reassurance to feel that they've done everything that made sense to consider. For others, they would look at you like you're crazy to suggest taking chemotherapy for 3 months for a 4 or 5% magnitude of benefit.
Well, that's kind of right where I am, and I'm going to discuss with her, and I thank you for your help. Sure. And before closing, I'm going to mention our website again, but I visited your website, and it's wonderful. So I really like to give you a chance to mention your website so our listeners can go there. What is your website address?
So I currently do my own podcast, an audio podcast called West Wind, which is available at iTunes and everywhere else you get your podcasts. I have that material and some video and other content at Beacon Medic, one word, BeaconMedic.com.
Okay.
And then I also founded a cancer education website for patients and caregivers that is at cancergrace.org, also one word. And that's a great place where I and many other experts just try to provide free, credible information that patients can have wherever they get their care, and have that be just a supporting evidence that can provide reassurance for them.
Yeah, that's the Cancer Grace. That's the one I've seen and sent patients to. That's really helpful. Well,
thank you.
Jack, I can't thank you enough for a really interesting talk. This podcast, we remind our listeners that this is the Blood and Cancer Podcast, and it is available on our electronic journal website, mds.com/hematology-oncology, and there'll be some nice show notes about all the high points of this talk on the podcast today very soon. So with that, I thank you very much, Jack, and wish our listeners a good day.
Take care. Thank you.
You bet. Thank you.
And that concludes the interview portion of our show this week. Don't forget, part 1 of the interview with Dr. Jack West is available. That's episode 43 of Blood and Cancer. That episode dropped on November 7th, 2019. You can find a link to it in the show notes. We'll be right back with Clinical Correlation. Welcome back to Blood and Cancer. I'm the voice of MDH Podcast's Nick Andrews. It's time now for Clinical Correlation with Dr. Ilana Yurkiewicz.
I'm Dr. Ilana Yurkiewicz, and this is Clinical Correlation, a segment about the human side of hematology and oncology care. One of the best, most appealing parts of a career in hematology and oncology is the continuity. In a typical career, you get to know your patients over years and have an ongoing relationship that is meaningful for everyone involved. That being said, for every doctor, there's still times, and these times are much higher when you're earlier in your career, such as in your fellowship, when you're covering, meaning you're not the primary hematologist or oncologist for someone, but are entering part of their story and having moments where your paths overlap. Instead of a full story, you get to see snapshots for these patients. It can be easy to think in these cases that you have less responsibility. You might think, well, I'm just covering. I'm not the primary. My role here is more limited. And while yes, the primary is often the most important caregiver for a cancer patient, there's still a lot of power in overlapping with someone even for a snapshot of their care. Because there's no timing for hard moments, they can come at any time. People will remember if you listen, are kind and compassionate, and care. They will appreciate if you dig into their medical history and make sure that the path they're on makes sense. Recently, I was called in to cover 2 days on an inpatient service when the fellow who was on for the month was unable to be there. I entered a patient's room, assuming the big picture plan was set in place, and I was just there to make sure it was going forward. Instead, he had question after question about the big picture. Why he was getting chemotherapy, whether he should get a transplant, and what would happen next if this didn't work. I didn't want to overstep because I wasn't sure what had been discussed previously, and I did not want to give conflicting information. I provided a listening ear, went back to the primary oncologist, and was able to circle back with some answers. It didn't really feel like much to me, but he was so appreciative. It would have been all too easy to fall into the background with an attitude of, well, I'm just covering today. Why don't you save these questions for your regular doctor? But with the privilege of being called a doctor who treats cancer patients, there's a certain responsibility that comes with that, and that's there 24/7. Even when you can't provide all the answers as a covering doctor for one day, it helps to remind myself you can always provide a listening ear, a comfort, presence. And those actions and their impact shouldn't be underestimated. Thanks for listening, and I hope you'll tune in next time for Clinical Correlation.
And that's a wrap on episode 44 of Blood and Cancer, the official podcast of MD-Edge Hematology and Oncology. Let's get to this week's credits. Blood and Cancer is hosted by MD-Edge Hematology Oncology Editor-in-Chief, Dr. David Henry. Clinical Correlation is written, recorded, and produced by Dr. Ilana Yurkiewicz. Our guest this week was Dr. Jack West. Blood and Cancer audio producer is Mary Ellen Schneider. Blood and Cancer is produced alongside all of our podcasts by MD-Edge executive editors Denise Fulton and Kathy Skarbeck and MD-Edge multimedia editor Terry Rudd. Social media is produced by Kyla Clark. I am your audio engineer, audio editor, and the voice of MD-Edge podcasts, Nick Andrews. Thanks for joining us this week on Blood and Cancer.